afternoon. I'd like to call the Senate Committee on Appropriations to order. Madam Clerk, will you please call the roll?
Chair Anthony.
Here.
Senator McCann. Senator Cherry. Here. Senator Bayer. Here. Senator Santana. Here. Senator Schenck. Senator Irwin. Senator Hertel. Here. Senator Kavanaugh. Here. Senator Kleinfeld. Here. Senator McMorrow. Here. Senator Camilleri. Senator Bumstead. Here. Senator Albert. Here. Senator DeMuth. Here. Senator Huizenga. Here. Senator Outman. Here. Senator Tice. Okay, perfect. Madam Chair, you have 17 members present. There is a quorum.
Thank you so much. We'll move on to adopting the minutes from the June 12th, 2025 hearing. I believe that is supported by Senator McCann, and without objection, the minutes are adopted. We'll first begin by a review of House Bill 4392 from Representative Borton related to the Natural Resources Trust Fund. This has been previously discussed and voted on in this committee hearing, and so as a part of our May supplemental conversation. So I believe we do have a few cards that we need to read this afternoon.
Madam Chair, all of these cards are relative to House Bill 4392. None of these individuals wish to speak, and they all are in support of the bill. Nicole Fisher, representing M. Parks. Chris S., representing the Department of Natural Resources. Carly Swartz, representing the Nature Conservancy. David Lucien, representing the Huron River Watershed Council. And the last card, Mike C., representing the Southeast Michigan Council of State Governments. And that is all of the cards, Madam Chair.
Thank you, Madam Clerk. Members, are there any questions? Okay. Seeing none, I need a motion to report House Bill 4392 to the floor with recommendation that it pass. I believe it's moved by Senator Bumstead, supported by Senator McCann. Madam Clerk, will you please call the question?
Chair Anthony.
Yes.
Senator McCann. Yes. Senator Cherry. Yes. Senator Bayer. Yes. Senator Santana. Yes. Senator Schenck. Yes. Senator Irwin. Yes. Senator Hertel. Yes. Senator Kavanaugh. Yes. Senator Kleinfeld. Yes. Senator McMorrow. Yes. Senator Camilleri. Senator Bumstead.
Yes.
Senator Albert. Yes. Senator DeMuth. Yes. Senator Huizenga. Yes. Senator Outman. Yes. Senator Tice. Yes. Madam Chair, on the motion to report House Bill 4392, there are 17 yeas, 0 nays. The bill is reported.
Thank you. I now need a motion to recommend House Bill 4392 for immediate effect. Moved by Senator Schenck, supported by Senator Kleinfeld. Without objection, immediate effect is recommended. All right, colleagues, we do have a lengthy agenda to have a variety of presentations to talk about the Michigan budgetary and economic impact of the federal reconciliation bill. So we will have a number of individuals from across the state to testify related to the impacts related to a variety of sectors. And we will first begin with Megan Groen, the Chief Deputy Director for Health Services, and Dwayne Haywood, Senior Deputy Director of the Economic Stability Administration with the Department of Health and Human Services, to come forward and give us a brief testimony. So thank you so much for being here today.
Again, Dwayne Haywood. I'm the Senior Deputy Director for the Economic Stability Administration, which oversees the SNAP administration.
Hi, Megan Groen, Senior Chief Deputy Director for the Michigan Department of Health and Human Services. I also serve as the State Medicaid Director.
And what I will do is just a bit, before we turn it over to Medicaid, I will just give the impact of the SNAP bill. Congress passed the bill July 3rd, 2025. It was signed into law on July 4th, 2025. The significant changes will be to Medicaid, SNAP, and the Affordable Care under the marketplace. New conditions of eligibility for federal funding cuts have a range of effective dates. And now I will just kind of, thank you. I will just kind of go over what is SNAP. putting healthy food within reach for people in need. SNAP provides food benefits to low-income families to supplement their grocery budget so they can afford nutritious food for essential health and well-being. Next slide. Who receives SNAP? 43% of SNAP households have children. 51% of SNAP households have a person with a disability. 36% of SNAP households have older adults. 78% of households have someone with earned income. And also, what's not on the chart, the 11% for our veterans, which is near and dear. I always pay attention to veterans. I am a veteran, so that's always something near and dear. The next is the SNAP impact. 9,700 retailers in the state of Michigan redeemed over $3.2 billion in FY24. The average benefit amount, $173 a month, which equates to about $5.68 a day. For every dollar that's invested with the SNAP into the community, there is a $1.54 realized in economic activities. And as we talk about the community impact, as Megan is going to talk about, health and nutrition, very important, very intersect for us. Reduced healthcare costs, certainly improves educational outcomes and support jobs in the economy as well as the supply chain. Some of the immediate impact that will be realized is the low-income home energy assistance grant that will go away. The removal of the internet will go away, and as you know, internet is how we really conduct business. Our MyBridges, we certainly encourage our customers as well as school projects for parents, and so that will be an impact. And then our able-bodied adults without dependents will change. There will be some changes with this particular part of the bill, and there will be adjustments. And then we also talk about the U.S. citizen and approval of the lawful permanent residents. That will change also. There will be some adjustments. In some cases, those benefits will be terminated for those who have in motion. If it's when the rules are promulgated in motion, if it's not set, then your benefits may be terminated. So let me talk a little bit about the SNAP error rate, and you're going to hear a lot about the SNAP error rate. And so let me unpack the SNAP error rate and what it entails. It entails the department as well as our residents and customers, and so we're linked together. And so with this a part of our program, we really have to make sure that we're working in sync, i.e., our customers. We have to have accurate and timely reporting. One of the things that we have noticed over the last couple cycles is that our client error has outstripped our department error, and so we really have to put a big focus on all of it, and that includes our client error. And as you can see, SNAP has one of the most rigorous quality control systems in the federal government. MDHHS works with U.S. Department of Agriculture, Food and Nutrition Services to identify payment errors. And again, just to talk about the SNAP error rate, customers and the department makes up that error rate. Our Bureau of Audit determines what the error rate will be monthly. So we watch it really, really closely on a monthly basis. If we are beyond 6%, then the state is in jeopardy of sanctions across the board. And even before the H.R. 1 was passed, Michigan was one of the lower rates as far as the error rates, or at least under the national error rate. But with the new bill, we will have to do a little more to make sure that it is realized and that our program is strong. So we talked about the error rate, and as you can see on the screen, $3.2 billion in benefits was paid out in FY 2024. And as you can see, we talked about the 6%, below 6%, zero impact to the state. However, as you can see, up to 7.99, 5%, the state will be on the cuff for, and that's $160 million. If we take the snapshot of where we're at now and we freeze it in time, we're at 9.53, and as you can see, that would be $320 million. And then it goes up after that to 10%, it's $481 million. And so in FY28, we will start, the state will be required to absorb some of those costs with the error rate. And then the administrative costs. There is an additional cost that will take effect in FY27, and that is an additional 95%. $95 million. What happened right now, we're at a 50-50 cost share with the federal government and state. Once the FY27 hit, we will move from 75-25, 75 being the state and 25 being the federal government. And what that means is, if you look at the chart, $287 million, and what that equates to from the $191 million is an additional $95 million starting in FY27. Some of the administrative costs, of course, is the staffing will be impacted, our staff training, technology, the fraud control, which we'll talk a little bit about. And we just understand that there will be some impacts with the administrative costs. And then I want to end with some key dates, and that is June of 2026, FY25 payment error rate will be finalized, and we will know the payment error rate for FY25. And I'll tell you why that's important. In June of 2027, our FY26 final payment will be posted. In FY28, that's when the cost starts. And so what happens is, in FY28, we have an opportunity to look back and choose between two fiscal years, 25 or 26. And so right at where we're at now in 25, 9.53, almost 10, we certainly don't think we will get at least, we'll get close, because we've been driving it down, but we don't know. So FY26 is going to be a really important year for us, and we believe that with the leadership, our leadership, Director Hertel, and all of our leaders, we think that we will do a very good job in driving it down, i.e., if you look at the example, the public health emergency, working with Megan and her team, it was a challenging task, but we got it done in 1 year. And so I think that we have the opportunity to sustain our program and now and into the future. And with that, I will turn it over to my capable colleague, Megan.
Good afternoon. I got it. Thank you so much for the opportunity to be here today. Thank you, Chairman. I really appreciate the opportunity to come to the committee and talk about some of the impacts of the federal reconciliation bill on the Medicaid program. I will start with a brief overview of the program. I know there's a lot of people here to talk about Medicaid today, so what we've done is some of the overviews of the program we went ahead and put as an appendix in the slides that you all have. So thank you for the opportunity to share those, and we'll just keep it pretty high level in terms of the Medicaid program and what we're talking about. As I think most of you know, Medicaid is the largest health insurer in Michigan and in the country. 1 in 4 people in Michigan are covered by Medicaid. You will hear nationally the statistic 1 in 5. That is accurate nationally, but in Michigan it's a little bit bigger. It's 1 in 4 people in Michigan are covered by Medicaid. So those are our friends, family, and neighbors who really count on Medicaid for well child visits, prenatal care, psychiatric visits, substance use disorder treatment, chemotherapy, and more. On that number, we listed out a couple populations. Just want to highlight that's also 1 million children. So 2.6 million people overall, and 1 million of them are children. Wanted to talk a little bit about, we talked about the populations that Medicaid covers. That doesn't always match up to the cost and where the dollars are spent. Of course, we're not giving checks directly to people to buy healthcare, right? We're paying providers and we're paying those bills. And so when we look at the bills we're paying, a very small number of the individuals in Medicaid are making up a majority of the cost. And so that's something that I think we really need to be cognizant of when we think about the Medicaid program, and both who is in it, who needs to be protected, as well as where those dollars are going. So seniors and individuals with disabilities make up only 15% of the people in Medicaid, but they're a really big population. They make up 47% of the costs in the Medicaid program. Medicaid pays for over half of the spending on long-term care in this state. Nursing homes receive more than $3 billion annually in Medicaid. And home and community-based service providers, so those who support vulnerable seniors and persons with disabilities living in the community, receive more than $1.5 billion in Medicaid every year. Wanted to talk just briefly about how Medicaid is funding and where those dollars go. Over 70% of the Michigan Medicaid budget is federal money. So when we're talking about impacts of a federal reconciliation bill, it's huge in the Medicaid program because that is where a lot of our money comes from. Because of the way the federal match rate works, if we are making cuts in Medicaid, for every dollar we're cutting, we're losing nearly $3 of money that's currently being spent on healthcare services. So that's both for our beneficiaries who count on that care, as well as the providers who their employment is delivering that care. Medicaid is a major player in the healthcare system. Nationally, Medicaid accounts for 1/5 of all healthcare spending, and it's the largest payer of mental health services, long-term care services, and births. I won't go over everything on this slide, but I wanted to make sure that everyone was aware of the different types of providers in the Medicaid program. Michigan hospitals receive nearly $7 billion in Medicaid funding annually. That accounts for almost 1/5 of the state's hospitals' net patient revenue. But it's not just hospitals. We have over 200,000 Medicaid enrolled providers across Michigan communities that are delivering that essential care and helping sustain the program for the 1 in 4 residents who depend on it. Listed here are just a few examples of the providers that count on Medicaid, including mental health care, long-term care for seniors, ambulance transport, primary care visits, and more. So we will talk about the following slides about the federal reconciliation bill. They'll show the impacts specific to Michigan. I've heard there's a lot in the news about what this bill did nationally. Want to make sure you're all aware of what that looks like for the state of Michigan, what that looks like for the residents here. And so we will divide this into eligibility as well as financing provisions. In general, when you look at what the Reconciliation Act did, it shifts a lot of the costs from the Medicaid program from the federal government to the states. And it draws new distinctions between the states that have expanded Medicaid, which is most of us, over 40, versus those that have not. So we will start with eligibility. This slide highlights some of the major changes to Medicaid eligibility. We'll go into more details shortly, but the changes include a work requirement, moving to 6-month renewal as opposed to an annual renewal, shortening retroactive coverage, and new requirements for non-citizen eligibility. I want to go over the dates really quick that we're looking at for work requirements. And the first one I want to draw your attention to is this June 1st of 2026. That is when the federal government, CMS, is required to provide guidance to the states. That's a really important date, and a lot of the answers to questions will be, I don't know, until we see that guidance. There are things we can speculate, but we will really need to see that guidance for a variety of reasons as we really move forward with important policy decisions and questions that we can't answer until that we have those additional details. I'm going to give you an example. So Michigan added a number of data sources recently when we brought back the annual redetermination process after a 3-year hiatus during the public health emergency. A lot of you had questions about redeterminations. I definitely sat up here and talked to a number of you, and there was a lot of really great work that went on in there. The Michigan legislature was extremely supportive to the department and with resources, which I'm very grateful for, and it allowed us to do policies that brought our ex parte rate, and this is things behind the scenes, paperwork behind the scenes. If I know that Dwayne and SNAP has your income verification, that we've done all of those things, well, gosh, the state of Michigan already has that, so Medicaid should be able to use that too. And so that can be done behind the scenes. So with a lot of the support that the legislature provided to us, we were able to move that ex parte rate, so the behind the scenes piece, from the low teens to around 60% today. That is something that's going to position us well for work requirements and for additional resources that we will need there. I would like to think that those data sources that we have used and added for that eligibility component will also be able to comply for a work requirement should, we're using payroll data and things like that, right? Will that work for that? I don't have the details from CMS to really know if all of those will work. And so if you hear things like we don't know, we're working on it, please know we are actually working on it and the implementation pieces, but there are some really big knowledge gaps on what we'll be permitted to do before we stand this up on January 1st of 2027. I talked a lot about what we don't know. We do know some things, and I want to make sure that I present those too. So CMS has shared that states will be required to implement work requirements beginning on January 1st, 2027. They've also shared that there will be few, if any, good faith waivers to states to push back that deadline. So we are really looking at that as, what we need to be preparing for. Beneficiaries will be required to have 80 hours per month of work or qualifying activities for those who are subject to a work requirement. For those of you who remember when Michigan stood up work requirements several years ago, the biggest difference with what we stood up before and what we'll be required to do in 2027 is that verification will be an application and renewal as opposed to a monthly verification. Wanted to go a little bit deeper on what some of those qualifying activities are. So it is 80 hours of work per month, but it could also be community service, participating in a work program, half-time enrollment in education, or a combination of those. Many people will be exempt from work requirements. We have them listed on the slide here. I won't go through all of them, but for example, if we can verify that they are medically frail, that they are meeting their SNAP and TANF work requirements, that they are a caretaker of a dependent child under 13, or otherwise exempt on this list. There are also a number of hardship exemptions, including counties with high unemployment rates or a federally declared disaster. Other hardship exemptions, especially important for this population, are individuals in a nursing home and other long-term care settings. I wanted to talk a little bit about some of the 6-month renewals and retroactive coverage limits. Beginning in January of 2027, Healthy Michigan Plan beneficiaries, so our Medicaid expansion population, will need to renew their coverage every 6 months as opposed to annually. That's twice as much paperwork for people to fill out and twice as much paperwork for local office caseworkers who are already stretched thin and will be charged with implementing this on top of the new staff requirements and the pieces that Dwayne was just talking about. That one I think is pretty simple, but I can't overemphasize how challenging that is going to be when we already see churn in the Medicaid population right now, right? We see people that maybe forget to turn in a piece of paperwork, don't realize that they need to do those pieces. It will be challenging to do this twice as frequently. In terms of retroactive coverage limits, I'm just going to start from the beginning of what that is. Currently, Medicaid will pay for medical services that were incurred up to 3 calendar months prior to the month of the initial application, as long as the individual was eligible during that time. They do have to be eligible for Medicaid, but if they're not signed up. When retroactive coverage is really important, and it's most commonly used, is in long-term care settings like nursing homes. When people aren't prepared, they may go into a hospital, they may be on Medicare, but Medicaid is who's actually going to cover the nursing home bills and those types of things. This gives people a little bit of time to figure that out. It also helps if someone misses a piece of paperwork and experiences a gap in coverage to make sure those providers are paid and those individuals are not going into Medicaid or medical debt. Beginning in 2027, traditional Medicaid will reduce that coverage to 2 months prior, and Medicaid expansion will change to 1 month. Not only is this hard for providers and beneficiaries, but it will also be hard for our caseworkers who will need to implement 2 different timelines for the Medicaid program.
And Megan, if you could just wrap up in a few moments.
Yep.
I know we do have a few questions from members.
Absolutely. So I'm not going to go over non-citizen eligibility too much. I just want people to be aware of the fact that Michigan does follow federal requirements for citizenship. And so since the federal requirements are changing, Michigan's requirements will be too. In terms of at a very high level, the impact of the eligibility changes is that we do anticipate significant coverage loss due to these eligibility changes. I want to take a moment and talk about financing. There's several major financing provisions in the Reconciliation Act, the most significant being to provider taxes. First, we'll talk a little bit about the state provider tax that funds the core Medicaid program, and then the one that supplemental payments to hospitals and physicians. The law changes how provider taxes work. In short, we do have one provider tax in the state of Michigan, at least, the insurance provider assessment, which we have been using since 2018, that will not be able to be allowable in the future. It's a $475 million cut that we use right now to offset general fund and base Medicaid cost. We have submitted comments to HHS and CMS, so to the federal government, requesting a 3-year transition period of this tax and the ability to restructure it during that transition period. That's something you'll probably hear a lot from us, because when we transition to a budget neutral tax, hopefully allowable by the federal government, that is something that we will need collaboration on, both with the federal government, but we will need state statute changes as well. I won't spend a lot of time here. There's a lot of confusing terms on this page, but what you need to know is these two pieces, provider taxes and state-directed payment limits, mean the department will be able to continue supplemental payments to hospitals, but it will be much lower. I will just kind of leave this that there are some additional financing-related provisions that take what the federal government is paying now and shift that cost to the states. It also opens us up to some additional audit considerations, just like Dwayne was talking about in SNAP. I will just leave you with what these changes mean for Michigan. So when we put these all together, we are looking at an annual loss of $630 million that's currently used to offset general fund costs and fund the core Medicaid program. They reduce supplemental payments to hospitals by $2.5 billion annually, and that reduced funding and declining coverage rates, we do believe will have, unfortunately, limit access to care across the state. And with that, I'm happy to take any questions that you have.
Thank you. I'll start. First, thank you both for coming before our committee and talking about the impact. The first question that comes to my mind is how the department is educating citizens about these significant changes. I'm thinking about the 1 million children. I'm thinking about individuals with different abilities and how we can communicate very significant cuts and reductions to services. So just talk to me a little bit about how the department plans to communicate and lessen the impact of these federal changes.
You want to start?
Sure. I'll go ahead and get started. So we're working very closely because a lot of our beneficiaries are the same people, right? And I don't know, they want to know about all of their benefits together and how this is going to impact me. So we are looking at letters to beneficiaries that kind of outline at a very high level, these are changes that are coming. This is what the impact is. We are also looking at putting up a website. Part of that is because it's good for us to get that information out there. Part of that is also because it really helps a lot of the partners that we have in this room and others that are close to our beneficiaries, right, that are someone who they know and trust. And it helps some of our partners be able to deliver that message at a community level and communicate with that as well. I presume we will also look at toolkits and things like that, again, to make sure that our community-based organizations have the information they need to be communicating with beneficiaries. We'll do the text messages, we'll do the phone calls, we'll do all of the things, right? But sometimes the state isn't the best messenger, and so we will be utilizing those partnerships as well.
That's why the partnerships are so very important, because the tentacles that fly throughout the state, and so it's going to be really important for our partners. The more information that we get out from the department into the community, the better it is for our customers to understand. And we will be following it up consistently.
Thank you. My other question, maybe more of a statement for members of this committee. This particular slide is probably the most impactful to our work. Over $630 million in lost revenue for our general fund. That is a significant hit. And as we are continuing to work through our budget process, trying to figure out how we contemplate all of the different needs and pressures to the balance sheet, knowing that because of congressional Republicans, we are left holding the bag at the state level. And it will not only result in significant impacts to health care and food assistance, but other priorities in our budget will suffer because of this intentional action at the federal level. So if, obviously this was a lot of information, we have the PowerPoints at our access, but as we are trying to, pass our state's budget, these are significant holes and significant pressures to our balance sheet. So Senator McMorrow.
Thank you, Madam Chair, and thank you both for being here. I'm wondering if you could speak a little bit to, even at a broad level, what the impact might be to other Michigan residents as these funds go away. Because what we know is if somebody is denied SNAP assistance, they still need food. We know that when kids go hungry, there are negative health outcomes. We know that when people don't have Medicaid, they may still need to go to the emergency room. They may still need medical care. Can you talk even at a high level of how that is passed on to the rest of us, even who may have private health insurance? I know Blue Cross announced they're about to raise their rates, 16% in anticipation of some of these costs? I'm hoping you can just address that a little bit.
Yeah, I think it's a really important point that you bring up, and thank you for raising that. And I think I can't give you an exact number, but what I can tell you is that uninsured people don't stop getting sick. They often wait until they're sicker to receive more expensive care, right? They're higher acuity, they're going to that emergency department as opposed to their primary care provider. When they can't afford to pay the bill, costs for everyone in that facility increase, right? Because that provider is then left holding the bag. That makes checkups, procedures, insurance more expensive for everyone. It will have a big impact in underserved communities. So many of our rural areas where 40% of individuals on Medicaid, if we do see, a significant shift, providers not being able to be compensated for that care, it's a good reminder that when a provider closes their door, they usually don't just close their doors for Medicaid. They close their door for everyone in the community. And, I think the ripple effects will be pretty significant, at least in the Medicaid population. I have to imagine there's similar things in Dwayne's world as well.
Yeah, because you're talking about the 97, I talked there a little bit about the 9,700 across the state. You think about the tax dollars that will be pulled. Certainly you will have to look at staffing in all of the grocery stores. You have to really look at inventory, the whole food supply chain. It will be a significant impact from top to bottom.
Thank you. Any additional questions? Senator Bayer.
Thank you, and it is a follow-on, so thank you for taking me next. In the same vein, when I think about the loss of hospitals, and that's ultimately what will probably happen, right? Because of the loss of Medicaid dollars in so many hospitals and nursing homes, right? They are so dependent on Medicaid dollars. And hospitals in particular will feel the pain because people would be going to emergency rooms for lack of health care. They go to emergency rooms. So add the cuts plus the additional burden on emergency rooms. And in nursing homes, they don't have any other thing to rely on. They're just out of luck with the Medicaid funding gone. I keep thinking about, where do those people go? What happens next to the people? What is the next step beyond that? So say we've lost 10% of our rural hospitals. What happens to those folks? How do we start thinking about what do we do?
Yeah, I will say, first of all, I think the Health and Hospital Association is coming up next, so this is a great question for them to address as well. But I will give it a go as well. And when I think about, how do we preserve these pieces of the Medicaid program to make sure that people have a place to go, right? And people showing up in emergency departments is the most expensive place we can have them show up, right? So how do we make sure that we're, doing what we can? And I think that that's going to take a lot of collaboration and, work with our partners in the legislature to make sure that, we can preserve these safety net providers, and through the Medicaid program, that's certainly something that we do now. There's only 3 places if you look at reducing Medicaid right, the dollars that you spend, right? It's on the services that we provide, it's eligibility, so it's the populations we serve, and it's the rates we pay providers. And I think, should that annual loss of $635 million in revenue that currently the federal government is paying, right, that the state will now, when we need to talk about numbers like that, it's a very hard place to be, because none of those are great options that I would recommend.
Well, and I'm looking at my mother who's in a nursing home. So if they have to close, and they won't be the only ones, what do we all do with our aging relatives, people that need care? I mean, it's hard to picture what happens next. Thank you.
That's right, thank you.
Thank you. All right, two final brief questions, Senator McCann and Senator DeMoose.
Thank you, Madam Chair. I don't see anything but harm here. And I don't think we'd be sitting here if this hadn't come from Washington talking about these changes. Can you go back to the last slide, which I thought I saw the 500,000 number. No, maybe it's, but there was a 500,000 number that you went through pretty quickly, which I think was the loss of coverage. And is that, I mean, we've added, have we not added under the Healthy Michigan Plan since 2013 about 500,000 people to Medicaid coverage since then?
There are currently about 750,000 individuals on the Healthy Michigan Plan, which can still be a plan, but there are significant eligibility changes that we kind of looked at that 500,000 number. That's taking them all together, right? So taking all of the different eligibility provisions, whether it's meeting a work requirement, not submitting the paperwork to meet a work requirement, or not doing it every 6 months as opposed to every year. So putting all those changes together, we do anticipate significant coverage losses.
Yeah, that's just a huge reverse, and I just think it's unconscionable.
Thank you, Senator. Senator DeMoose?
Thank you, Madam Chair. This is an actual question. It's not an argument, because the process is a bit hard to follow at the federal level. I think we'd all agree with that. But it's been explained to me, and I've heard conflicting reports on this, that some of these changes require other pieces of legislation to happen, especially when you're looking at fiscal year 27, 28, and beyond to the 2030s. Are all of these cuts and changes locked in now, or are they still dependent on more legislation? Because I've heard conflicting reports on that.
Okay, so I can only speak to the Medicaid program, but I'm more than happy to speak to that. All of the things that we just went over today, including the things I kind of breezed over, I do not anticipate additional federal laws needing to be changed. We are waiting on pieces of guidance, right, in order to understand a little bit more. So work requirements, I know it's 80 hours, but what count, like as we get into those details, but not actual law changes. I don't know, Dwayne, if that's the same in your space.
And the same. They're pretty much locked in, but we're just waiting on additional guidance. But those costs are coming. We just need to make sure that we're prepared.
Thank you both again for your testimony.
Thank you.
Appreciate it.
Thank you.
We'll now bring up Laura Appel from the Michigan Health and Hospitals Association. And for the remaining testimonies, we're going to ask for folks to keep it within the 5-minute range so that we again have time for questions from members. So thank you for being here, Laura.
Good afternoon, Madam Chairwoman and committee members. Thank you so much for having us. I'm Laura Appel from the Michigan Health and Hospital Association. If you go someplace that has an emergency room, it's probably one of our members, as well as many behavioral health and other types of hospitals. So yes, all Michigan hospitals are facing devastating cuts in Medicaid funding as a result of this act. And this in turn will impact access to care for Michigan patients, as Senator Baer brought up. The act will reduce hospital payments by more than $6 billion over the 10 years of the act, and Senator DeMoose, that exists. That's not subject to, I mean, there will be regulatory action, I think, perhaps on exactly how to do that, but the numbers are set as of now, although they could be made better or worse, I guess. Independent and rural hospitals, I think, will be hit the hardest but every Michigan hospital will be seriously injured by these cuts. And I think Professor Michael Shepard might be here. He's an expert in rural health specifically and could talk more about how he sees the rural impact of the act. You're probably aware of many aspects of the act are not implemented right away. So, we have a few, as the department mentioned, there's some time to get ready. Hospitals, however, and Senator Heisinger probably knows this better than I do, work on a very long-term basis. And so right now, we had a call last week with our hospitals, and they said, yes, we are looking at whether or not we will fill vacancies. Our boards are already revisiting capital investments in upgrading equipment or modernizing facilities. And the worst of the impact might, it might begin after the 2026 election, but for hospitals, the decision-making is starting right now. We do expect that hospitals will experience growth in uncompensated care when people lose coverage due to these new requirements. We would absolutely concur that eligibility must be accurate, but the systems used to make these determinations must also be so. And we do have experience from other states where they tried to implement some of these things and it was not successful, and people did lose coverage even though they were working. People did lose coverage even though they were exempt from a work requirement. And we know that those folks incurred more medical debt, delayed their care, and some prescription drugs were foregone. Yes, when people become uninsured, they usually turn to the emergency room for necessary services. They might be further away. One of the things that we saw before the expansion of Healthy Michigan was people could not afford insulin, and they ended up hospitalized because of complications of that very terrible disease. And we've done a great job of eliminating that so far with our coverage expansion. And, hospital emergency departments are already working at a kind of at their max capacity. And one of the things that one of our hospital CEOs mentioned, she said, I already have, the folks are here with trauma and chest pain and severe lacerations and broken bones. Adding people who need help with their chronic illnesses will be a burden to the resources. We'll try and do everything we can to make sure everyone is taken care of as efficiently as possible, but wait times almost certainly will increase. And you can imagine the other impacts. I want to make it clear that the number I've shared, this more than $6 billion, is very specific to the new restrictions on the way we do Medicaid provider taxes in the state. It does not incorporate those coverage losses or anything like that. We do have provider taxes not only on hospitals but also nursing homes and ambulance services. And I was actually around when we started doing this in fiscal year 2003. The Engler administration determined that it was not a great year for Michigan, as many years weren't, that we didn't have sufficient funding, general funds for Medicaid, and that hospitals would forego the coverage that they had for physician residency programs, where we do training of physicians in the hospital. And so we were told, if you will pay a provider tax in lieu of the general fund, then you will be able to keep that program going. And over the next 20 years, we just became more and more dependent on this system. But using provider taxes, we can maximize our Medicaid matching funds at the federal level without going beyond what's allowed by law. And we don't have to impose higher taxes effort on individuals or corporations. So while the cost of labor, prescription drugs, supplies, et cetera, number of people enrolled in Medicaid have all increased very significantly. If I had a chart that I could show you, and I didn't want to belabor this point, the investment of general fund has been really steady, so we didn't have to find more general fund for Medicaid because we used this tax instead. I just want to make it also very clear that while hospitals are planning for these cuts and thinking about this right away, no one should yet, from the results of this act, have experienced any change to their coverage. And I hope that people are not foregoing any care. If you need services, you should go see your clinician just as you always do. Use the emergency department as appropriate. Get your prescriptions filled. There's a lot of news about this is not great for people using Medicaid, and that's true, but not yet. So please don't forego the services that you need. And finally, there's a lot of details here, and Senator DeMoose asked a great question. the MHA is available to any of you and your staff at any time to go deeper into any of these, any part of, how this affects healthcare. And I would just close by saying I didn't mention anything here about SNAP, but we don't have a very specific knowledge about what lack of food will mean, but food insecurity does seem to have an impact on people's health as well. I can't quantify that, but I agree that that's a good, to think of in combination. So again, thank you all for your time today.
Thank you. Thank you. Members, are there any questions? Senator Irwin.
I want you to kind of unroll a sort of more granular example of what I think Senator McMorrow was asking about and that you hinted at. So just like we saw before with Medicaid and with changes to Medicaid eligibility, when this does change, there's certainly going to be many, many people who are still eligible, but because of the new bureaucratic requirements, because of the new paper requirements, they're not going to do that paperwork. But then they will get sick, and then they will come to the emergency room, and your members will be legally obligated under EMTALA to treat them. Mm-hmm. So what happens to those bills? Could you just kind of walk through that example?
You mean what happens?
Because we've all heard that those costs end up still being in the system, and they end up still being picked up by the rest of us who are either paying private insurance or what have you, or maybe your members eat it. Talk to us about how that affects your members when people show up who would otherwise be eligible for Medicaid, but because of their paperwork not being in order, they're not, and now you've got unpaid bills that result in medical debt and then unpaid medical debt. What's the end of the line for that?
Yeah. I wish I could tell you that was like a very clear and simple thing that, we just say, oh, wow, we're going to be short, a hospital organization would say we're going to be short $10 million, and we've got to pass that on to our third-party payers or, whoever. But as you probably all read in the news, hospital contracts with third-party payers are multi-year contracts. And so there's not really many provisions in there for, wow, you had this massive increase in uncompensated care, how might we change what we pay you to make up for that? It doesn't happen that readily. I think it does put pressure on the commercial market, but commercial coverage is also not expanding, it's contracting. So we're becoming more and more of the healthcare system is more and more dependent on government payment from Medicare and Medicaid. It will tax hospital resources. I think for a lot of that uncompensated care, they will not expect to achieve reimbursement. Also, the folks, if you have such limited resources, you probably qualify for hospital charity care policies, as you should. And so again, that will grow. The output there will grow. So I think it puts pressure on all areas of the system. It will curtail the ability to hire. It will curtail the ability to invest and upgrade and things like that, as well as putting pressure on the commercial insurance market.
So the market got more and more dependent on public sources, and now Congress is kicking away the supports on that and removing some of those public sources. I think that problem is going to roll downhill, just like these problems always trickle down on the least among us. And I think we're going to see even more pressure on that private market. I think we're going to see premiums going up. I think we're going to see hospitals closing. And I think that what Congress is doing is a disaster for our providers, and it's certainly a disaster for state government, where we're seeing these massive bureaucratic cost increases.
One thing I didn't mention about the cost pressure is, I am, and the hospitals, the MHA, I think we are all empathetic to employers that are trying to do the best they can to provide coverage for their employees. And what they get faced with is try and do this, but also, keep it going. And where that pressure ends up is higher copays and deductibles, which is greater out-of-pocket expense even for those folks who are insured. Yeah.
We'll take one more from Senator Schink, and then we'll move on.
Thank you, Madam Chair. So as we're listening to all this, it's a little complex and confusing, and so I just want to distill it. So I think what I'm hearing is that these Republican cuts are likely going to raise our costs for all of us, for most of us, and restrict our access to care.
I want to, the cost might stay the same, but the number of people available to spread it among would be different. So it's not like you're going to raise
No, I
the
mean,
price. But you know what I
For
I
a
think.
person, what I heard is that our insurance rates may have to go up.
Could go up, yes.
The provider may have to charge us more because there are some people who won't be able to pay. So it sounds like for many of us, even those of us who are not on Medicaid, that it could potentially raise our costs, but there may actually be fewer providers because some will not be able to provide care at all.
And again, I know Dr. Shepard's going to speak, so I don't want to preempt what he knows better than I do, which is we do have hospitals that are in financial difficulty. Every state does. And this could compound those financial difficulties. And it almost certainly, I know a few hospitals who've said to me, we will be looking at services. They haven't said, nobody says we're going to close our doors, but services are on the block, and that will reduce access. You're absolutely right. And I can't remember, I think it was Senator Bear had the question about what happens. We do know from research, this is not specific to Michigan either, that when people have to travel further for emergency services, the outcomes deteriorate. Having to go an hour instead of 20 minutes, if you're in bad shape, that doesn't work. So, thank you.
One more quick one from Senator Kleinfeld.
Thank you for giving me the latitude. I really appreciate it. I just need to touch on something. You said the cost may stay the same, but be spread over a smaller number of people. Would you agree that the impending tariffs are anticipated to have a cost impact on the hospitals?
So,
And I
short
only
answer,
have
yes.
a very short, she's given me latitude, so.
Short answer is yes. For example, I believe that there is a surprising number of prescription drugs that are imported from Ireland, and that tariff will hit. And, we had a shortage a couple years ago of some chemotherapy drugs, and the price skyrocketed. And in one case, it was 50 times what the usual dose is. The usual dose was $11. It went to $550.
So I just wanted to clarify, we're having policy at the federal level that drives up costs and then spreads it under a smaller amount of people who are least likely, who many are least likely to be able to afford it. Thank you.
Thank you. Thank you, Laura. Appreciate you. All right, we'll now turn it over to Rachel Richards with the Michigan League for Public Policy.
Good afternoon, Chair Anthony and members of the Senate Appropriations Committee. I am Rachel Richards. I'm the Fiscal Policy and Government Relations Director for the Michigan League for Public Policy. Thank you for the opportunity to speak about the ripple effect that the federal mega bill will have on Michiganders, our state budget, and the larger economy. Medicaid and the Supplemental Nutrition Assistance Program, or SNAP, are critical to Michigan's prosperity, supporting thousands of jobs and businesses. They also generate hundreds of millions of dollars of tax revenue that underwrites the state and local services on which we all rely for a high quality of life. It's sometimes said that one loss is a tragedy while 1 million is a statistic. This statement illustrates why it is crucial to remind ourselves, especially as a data-driven organization like we are, that we're not simply talking about statistics or abstract budget calculations. The cuts to these programs will have real and stark implications on Michiganders' health and economic security statewide. The more than 500,000 Michiganders projected to lose health coverage and 74,000 at risk of losing SNAP benefits represent the family members, friends, neighbors, and colleagues whose health and financial security will be at risk. The health impacts from these cuts will weaken the state's workforce. This means missed days of school and work, lower academic achievement, and lower earnings. 1 in every 10 Michigan workers participates in SNAP because they are not paid enough to feed their families. With even fewer resources for food, we can expect higher worker absenteeism and lower productivity due to health issues like diabetes, asthma, and hypertension. The federal mega bill's attack on our workforce will further undermine vital community institutions like hospitals and grocery stores that will already be directly threatened by the loss of Medicaid and SNAP revenue. For example, the 5 most common jobs among Michigan's SNAP participants are in the food supply chain and the healthcare system. Losing health coverage often means delaying or foregoing preventative and acute care, increased reliance on hospital emergency rooms, and higher uncompensated care costs for providers. And these outcomes have ripple effects on our economy. Hospitals reduce staff, demand on local public services increase, and working families are left to decide between paying the high price of health care or other essentials like food. And for the about 450,000 Michigan households who are enrolled in both programs, increased hunger will create greater health threats while access to the care they need is taken away. Facing greater out-of-pocket costs for vital medical care, families will have to cut spending on other survival needs like food. And to be clear, reductions in the total Medicaid and SNAP spending do not equate to savings for the state. Instead, reductions represent a loss of funding that currently supports essential nutrition, health coverage, and provider reimbursements. The federal mega bill doesn't simply reduce federal spending, it shifts the cost burden onto states, with Medicaid expansion states like Michigan hit even harder. Poverty is a policy choice, and the federal mega bill has shifted these decisions onto the state and onto you all. State lawmakers will soon be tasked with making a choice between 2 unpopular decisions. 1, replace lost federal funding with state dollars, most likely from the general fund, which will require redirecting resources from other priorities. Or 2, cut the Medicaid and SNAP programs by reducing how much is paid to healthcare providers, eliminating certain optional services, or tightening eligibility. Both of these options will result in cuts to vital services that we all rely on, and neither option is acceptable. We are grateful to be here today alongside so many close partners to be a resource and to voice the need for state lawmakers to begin planning now for these fiscal challenges. Whether through identifying sustainable revenue streams, leveraging opportunities to extend Michigan's transition timelines, or mitigating administrative barriers to coverage, proactive steps are needed to protect our state's Medicaid and SNAP programs for the millions who rely on them as their lifeline to necessary food and health care. And I'm happy to answer any questions.
Thank you. Senator Kleinfeld?
If we take on and try to cover the costs as a result of their cuts, aren't we incentivizing them to do it further in further budgets in other areas and even deeper in this area? If they don't get any blowback from anybody because we're trying to cover it, and I've already heard the president indicate, well, the state should handle more of their natural disasters. You know, the state should handle more of this, the state should handle more of that. I see an incentive the more we try, and I'm concerned that with everything else he wants to shift on us, he's going to break our back. And we may have to seek more revenue to cover it. Ultimately, the revenue's still being sought, whether it's from him or us. It's just that the tax cuts from them are going to a different set of the population than we would like to see here, though. But your opinion, do you think if we tried to absorb all of this, that would be an incentive for the federal government to do that even further?
I don't want to speak for Congress, for the federal government, but I'll say, there are definitely some stark concerns with trying to fill the hole. I mean, we're going to ultimately have to pull from other areas of the budget that we already are, currently underinvest in and have decades of disinvestment in some of these areas. And I think we're just, shifting around those dollars. If we're trying to, it's kind of like robbing Peter to pay Paul. We're just kind of shifting around dollars and therefore creating even bigger crises in some other areas.
I would agree with that. I'll go out on a limb and say it would be an incentive. We fill the hole, they'll go dig another hole. Give some more tax breaks to some really rich folks. Thank you.
Thank you. Senator Shink.
Thank you. Do you think that it's likely that there's some kids in Michigan who are going to go hungry because of these cuts and go without the health care that they need because of these cuts?
I think there's definitely a very real concern about that. There are families that are currently covered through, and one of the pieces that I didn't talk about were some enhanced premium tax credits that families receive in order to help them pay for their health care on the Affordable Care Act marketplace. And so, if we are eliminating some of these tax credits that currently subsidize and help them afford those health plans, and if those premiums go up and they're unable to pay for them, they'll either have to choose, to go without food, they'll have to choose to go without health care, and this is going to impact families. So I do expect that we will see, definitely tough decisions being made within a number of families as we, see these cuts get implemented.
Thank you. Any additional questions? Thank you again. Thank you for your testimony. We'll now move on to Dr. Michael Shepard, Assistant Professor of Health Management and Policy at the University of Michigan, to testify. And I think that the slides that are before us, he will be referring to. So thank you for being here.
Thank you all for having me. So some of this we've already covered, and I'll pass through as quickly as possible. About 2.5 million Michiganders are enrolled in Medicaid, and of that group, just under 1/5 are rural residents. Depending on your source, about 3/4 of the Michigan Medicaid program is funded by the federal government and is now facing tremendous cost. Estimates from the Kaiser Family Foundation suggest that Michigan is set to lose $5.6 billion in federal funding for federal Medicaid funding for rural areas exclusively over the next decade. Included in the reconciliation bill was a rural health transformation fund that includes a certain amount of money to offset some of these losses. However, the best estimates suggest that only about 1/3 of the estimated losses from Medicaid can be made up from the Rural Health Transformation Fund. And so the loss of Medicaid funding in rural communities across Michigan will be devastating for both health and economic reasons. There are numerous counties in Michigan, especially in rural communities, where over 1/4 of the population are current Medicare enrollees, some as high as 40%. These counties are facing particularly large losses to their health provision as a result of the cuts. Here are just a list of the rural counties in Michigan, for example, that have the highest percentages of folks who are enrolled in Medicaid. If we look at the overall economic activity or economic output of the Medicaid program, one scholar's estimates, this is a professor at the University of Michigan as well, estimates that nearly 10% of the economic base of the Upper Peninsula and northern Michigan in the 1st Congressional District are funded essentially by the Medicaid program. In southern Michigan along the Indiana and Ohio borders, roughly 8% of the local economic base is made possible as a result of Medicaid. That includes revenues that hospitals are taking in, as well as other medical providers, and the sort of spillover effects of this funding on the economic situations of these communities. If we look across the state, there are numerous rural communities where the healthcare industry and rural hospitals in particular are the largest employers. So healthcare in general is the largest employer in every region of Michigan and in the state overall, but also 1/3 of the rural counties in the state. And so what that means in large part is that economic effects that are likely to occur as a result of the Medicaid cuts will not only impact the individuals who are directly enrolled in Medicaid, but will reverberate throughout rural economies in the state. My own work has shown that Medicaid has been critical for saving the remaining rural hospitals that we have in Michigan as well as across the country. So since 2005, about 200 rural hospitals have closed nationally. If we look at a variety of different data sources which account for the financial situations of remaining rural hospitals, about 1/3 face risk of closure in the near future. all of that prior to this most recent changes to the Medicaid program. Overall, about 20% of the typical rural hospital spending comes from Medicaid. And so what we're talking about are massive cuts to the financial operations of entities that are by and large already struggling. This in part is because Medicaid and Medicaid expansion in particular drastically reduced the uncompensated care loads faced by rural hospitals. Uncompensated care, as we've already talked about a little bit, is essentially the care that's provided to individuals who lack the income or the health insurance to pay for the medical attention that they receive, often in an emergency department. Federal law requires that the hospitals essentially pick up the tab and provide appropriate services for these folks. Oftentimes, what this leads to are ballooning holes in rural hospital budgets. And this problem is particularly difficult for rural hospitals because the profit base is so much smaller. We're talking about more people with lower incomes. We're talking about more people who lack health insurance, and fewer, more profitable patients for the hospitals to make up the difference. So in many rural communities and rural hospitals, uncompensated care is a real financial threat to the survival of the hospitals. What we can see is that after the passage of the Affordable Care Act, and actually more specifically after the Supreme Court announced that states were allowed to opt in or opt out of the Medicaid expansion, hospitals reacted across the country. So starting in 2012, what we see is a bifurcation in the financial health of rural hospitals across the country. In states like Michigan that expanded Medicaid, the number of rural hospital closures has dwindled down to 1 or 2 per year, whereas rural hospital closures have increased in number in the states that have not expanded. That's not to say that hospitals in Michigan, especially in rural Michigan, aren't financially struggling already. Based on the best data that I've had access to, about 21 of Michigan's remaining rural hospitals, which is about 30% of the currently operating rural hospitals in the state, have negative financial margins. 4 rural hospitals operate on negative 10% or worse financial margins. As a result, cuts to the Medicaid program that will be experienced over the next few years directly threaten the financial health of at least these 4 hospitals. Most estimates would also include hospitals that run negative margins from negative 5% and beyond. That gets us 9 more rural hospitals. The map that I've provided on the right are all of the counties in the state that have hospitals that are currently operating with negative 5% or worse financial margins and thus face various risks of closure in the near future. In most of these communities, the hospital is the largest employer. And what we would expect to observe are a series of spiraling negative effects as a result of the closures. So earlier someone asked what happens when these hospitals close. We have quite a lot of evidence that nothing good happens and quite a lot bad happens. For most folks, what this means is increasing distance to care of pretty significant distances. So if you think about if you're living in the Upper Peninsula and you're expecting to give birth and that hospital is no longer there, what we're talking about is an increased drive of 40 minutes, an hour, in some cases an hour and a half. The best evidence that we have suggests that every additional 30 minutes drive to a hospital is increasing mortality risk for a variety of different causes, worsening birthing outcomes, and has other spillover effects on the medical provision in the community. Oftentimes, in an attempt to survive cuts or weather financial storms, these hospitals begin laying off particular specialists. So oftentimes, labor and delivery are the first things that are cut, in part because in rural areas there are so few child births that ends up not being a profit center for the hospital. And about half of rural births are covered by the Medicaid program. And so what we're looking at is essentially a double whammy when it comes to labor and delivery. The hospital essentially moves down the list of units that are the least profitable, attempting to close them or partner with other hospitals in the region to make up this difference and service provision. But oftentimes, for most folks, this means increasing drives that threaten their health. Economically, these hospital closures have dramatic effects. Again, in about a quarter of rural counties in Michigan, hospitals and healthcare providers are the largest employers. What we see is after a hospital closes, the median income in a typical community declines significantly. Unemployment rates spike because, again, they're the largest employers in the community, and this leads to other downstream effects on the economy as well. It's difficult to recruit new employers to rural communities that lack hospital care, in part because most people want to locate new manufacturing operations, et cetera, in communities that have resources that can support the community and not ones that have experienced loss. And so what we really observe in the case of hospital closures, which are more likely now as a result of these cuts, are effects that trickle down to the entire community. It doesn't matter whether or not you're directly enrolled in Medicaid. When your hospital closes, regardless of what your source of insurance is, you now have a longer drive, and your healthcare outcomes will suffer. Your economic situation in your community will also suffer. If you're someone who works at the hospital, you've lost your job potentially, and for many of these communities, the next closest hospital is pretty far away, which might involve moving your family altogether, uplifting your roots to move out of the region that you call home. And for many rural folks, that is a not exciting proposition. Most people in these communities are deeply fond of where they live and care a lot about the trajectories of their communities. And these effects are seismic and severing that attachment to place, but also the long-term health and economic wellness of affected communities. Thank you.
Thank you, Dr. Shepard. Members, are there any questions? Senator Schenk?
Thank you. I appreciate your testimony and the work that went into it. I think what I'm hearing is that these cuts that Republicans in Washington make are going to affect our most rural districts pretty heavily, and that people who live in those areas, some of them may be in my district, but I think a lot of them are probably in a lot of other districts too, are going to face higher healthcare costs, fewer options, worse outcomes, which could mean death or brain damage for whatever the thing is, whether it's a birth outcome. I mean, when we say birth outcome, it sounds to me like we're going to have more babies not survive birth, maybe more mamas not survive birth, maybe more brain damage and special education needs. But it goes beyond that, because it also sounds like in the communities where these hospitals are already struggling, and I know we've passed some legislation to support them, and we've done some things to support them, but these cuts are so massive that these communities are likely to see a downward spiral in their economy, which is going to, in a sense, bleed out more residents, and it just sounds so depressing. Do you think that's a pretty good synopsis? That we're looking at not only reduced healthcare options, we're looking at more suffering, and we're looking at hurting our rural economies in a big way.
I would say most of that is a fair characterization. In many of these communities, rural hospitals are anchor institutions. They're large employers. They provide not only necessary services, but a sign of a community strength and resilience. Losing them has a variety of negative consequences that can occur both economically, socially, and in terms of health. Fewer options, restricted access are almost assuredly guaranteed when hospitals close. Most of these places don't have backup hospitals. When the hospital closes, it's the only one in town. That might mean that there's one the county over for some select few, but my research has shown that in many places that have lost their hospitals over the last 6 years, they also lost their second closest hospital, and in some cases they lost their third closest hospital, which means the increasing distances sort of mount exponentially. And, medical providers often will quip the phrase time is tissue, and essentially what that means is that the longer it takes an individual to get to medical care, the more significant the costs of whatever is occurring, whether it's a car crash or a stroke. And so when you're talking about rural hospital closures, you're talking about worsening outcomes and potentially higher mortality risk for virtually any cause, just due to that amount of time that it now takes to get care. So I would say overall, most of that I would agree with.
Thank you.
It's so sad for billionaire tax breaks.
Thank you, Senator. Senator DeMoose?
Thank you, Madam Chair. I just want to ask you, I mean, is it not true that none of this is set in stone? That we, in fact, in this building have the power to make sure none of this happens? Because I'll tell you why. I mean, look at our own business, our own budget. We've gone from $50-some billion to $84 billion in just a span of a few years. And if we sharpened our pencils and had to decide what really matters to us as a state, which to me, all of these things, SNAP, Medicaid, really do matter to me, we may have to cut some other things, but we could still make up that gap. And I guess I'm asking you, could we not make it within this body, if we got creative about how we spend our money and how we didn't spend our money, that we could make none of this happen? Because part of me, while I don't love what's happening in a lot of ways in Washington, D.C., decade after decade after decade, Republican and Democrat, of overspending seems to have finally caught up with us. We're broke. We're $37 trillion in debt. And so I think by shifting this back to the states, it maybe makes our job here harder, but can we not solve this problem amongst ourselves here?
I would say that it's fair to say that some of the problem can be overcome with state government policymaking, some of it less so. So the work requirement aspect of this, which is being induced at the federal level, is going to lead to the loss of coverage, and that must be followed. But there are other aspects of this that spending money at the state level is essentially the only fix, at least in the short to medium term, to what's going on. In terms of whether or not this is set in stone, at the federal level, that appears to be the case now, but there are some individuals in the Senate, for example, that have at least suggested that they would be opening to revisiting the Medicaid cuts at the federal level, the Medicaid changes at the federal level, which would change the playing field here. But I think most states now are wrestling with the question that you've just asked, which is what can be done at the state level to fix this problem, and not so much the question of whether or not it should be. I think most people can see the negative effects that this will have on many communities and on many individuals. And there are a variety of different options that you have at the state level to shift how money is spent. But again, I would highlight that that's taking money away from other priorities and focusing on this, which is a decision ultimately, that you get to make.
Yeah, it's a decision every family has to make, is balancing what's important to you and what's not. So thank you.
Thank you. Senator McMorrow?
Thank you very much. This is a really sobering presentation. I wonder if your research has found rationale as to why more rural hospitals have consistently over time relied more on Medicaid funding than other sources, and is it because that the population is aging and that wages are being reduced? And if so, is it fair to say that what you are suggesting with hospital closures would exacerbate those situations and make it, we talked about birthing centers closing, even less likely that there are babies being born and population ages getting younger, and does that just accelerate the issue instead of solving it?
Yeah, a good deal of this is compositional. So rural people are disproportionately likely to be enrolled in the Medicaid program in virtually every state. Rural people on average have lower incomes and therefore lower amounts of disposable income to spend on health care. Oftentimes in rural communities, hospitals provide the only available forms of medical care, and all of these forces sort of make the financial situations facing rural hospitals particularly precarious. It's certainly the case that what we've seen is that at least, many rural hospitals have never been particularly profitable, in part because of these compositional changes. But over time, starting in 1986, for example, as the federal government required services to be provided, regardless of an individual's ability to pay, we've sort of seen a steady trickle of rural hospital closures brought on in part by this precarious financial situation. As incomes in many rural communities have stagnated or decreased, we've seen an uptick in the amount of rural folks who are enrolled in Medicaid. And as a result, rural health providers of a variety of sorts, hospitals, mental health, et cetera, are disproportionately reliant on the Medicaid program.
Right, and we have to close out from here because we have a couple more to get through, but thank you so much, Doctor. We
Thank you.
appreciate you. Next, we'll turn it over to Dr. Quentin Tyler. He's the Director of MSU Extensions.
Yes, thank you, Madam Chair and members of the committee for this opportunity. I am the Director of Michigan State University Extension, and I have to my right the Associate Director of our Health and Nutrition Institute, Aaron Moore. Within the budget that was signed into law last month was the elimination of the $530 million SNAP education program. This means that two implementing agencies in Michigan, MSU Extension and Michigan Fitness Foundation, will no longer be able to continue this program effective fiscal year 2026. For us at MSU Extension, that means the loss of $10 million annually and the loss of 94 of MSU's Extension SNAP education programming and community-based positions across the state. More importantly, it means the end of a 30-year legacy of delivering high-quality, evidence-based nutrition and physical activity programming across all of Michigan. To reiterate, our SNAP Ed work isn't confined to a single community. It was a statewide network. We have educators in nearly every county working directly with families in schools, food banks, community centers, and health clinics. Losing this program means losing our ability to teach parents how to prepare healthy meals for their children, to help seniors navigate grocery stores with healthy choices in mind, and to support community gardens that increase access to fresh produce. It was more than a job. It was a purpose. These 94 Michiganders devoted their careers to improving their communities and helping their neighbors live healthier lives. Embedded into our communities, they teach adults with developmental disabilities how to try new vegetables and fruits. They help children learn how to be more physically active and focus better in class. They improve our schools, our neighborhoods, our Michigan communities, and our lives. Last year alone, SNAP education reached more than 115 Michiganders. We partnered with over 1,000 local community organizations and over 200 coalitions. We worked in school cafeterias, senior citizens, senior centers, farmers markets, and food pantries. We connected child care providers to Michigan farmers through innovative CSA box programs. We help kids who don't get enough to eat at home by working with local high schools to build free refrigerated food pantries. All of it made a difference. With the funding support for that work gone, over 100,000 Michiganders each year will lose education on how to become healthier. More than 1,000 organizations who need a trusted community partner to help them will now be left without resources and partnerships. The folks they serve, whether they're military veterans or young kids, will be deeply affected by this loss of services. Coalitions across the state will have empty seats at the table where MSU Extension staff once were, contributing to local efforts. Unfortunately, the breadth of SNAP-Ed's work is matched only by the magnitude of this loss. And we are already hearing from our partners and stakeholders who are rightfully concerned about what this means for them. For example, a partner in Hale area schools shared with us they have no health programming for their students without MSU Extension. No full-time nurse, no health class. MSU Extension SNAP-Ed program was it. But without us, those students lose access to the only nutrition and physical activity education they had. In Alcona's community schools, the superintendent and principal told us they will profoundly miss this partnership because our team didn't just teach classes. We helped transform their cafeteria environment. Alcona was also a food corp site, and our partnership helped elevate their work impact. Together, we show kids what it means to make better food choices and why that matters. That support is now gone. Michigan is unique that it's second among states in the U.S. with over 300 commodities, and we at MSU Extension work hand in hand with those commodity partners. In particular, they have told us that without SNAP-Ed, many SNAP benefit recipients would not prioritize or understand the importance of purchasing fruits and vegetables. If fresh produce sales decline, Michigan farmers and local food economy will feel it. What happens in a grocery aisle today ripples into family kitchens, fields, and farm income tomorrow. When you eliminate a program like SNAP-Ed, you just don't cut an item in the budget. You erase lifelines in schools, neighborhoods, and communities that already carry the weight of health disparities and economic strain. You also lose a highly trained and deeply embedded professional workforce, people whose roots were firmly planted in Michigan's counties they served, people who reinvested their salaries into other Michigan businesses, people who help children eat better and families stretch their food dollars further. This program was a legacy that supported schools, strengthened farms, and empowered children and families to become healthier. MSU Extension is uniquely positioned to deliver this program effectively and efficiently. Our long-standing relationships with communities and our history of evidence-based programming ensure that our SNAP-Ed efforts are both trusted and impactful. We reach people where they are, from the Upper Peninsula to the Michigan-Ohio border, who are an essential and important part of Michigan's fabric. We have a proven track record of success with countless stories of individuals and families who have transformed their lives through skills they've learned through our SNAP-Ed programs. These are real people who now have the real knowledge to manage their health and their budgets better. The biggest challenge we now face in the upcoming months in this state and across the country is knowing that while funding for SNAP-Ed is gone, the problems it helped solve and the needs it met are still here. Thank you very much for this opportunity to speak here today.
Thank you, Doctor. Members, are there any questions? Very thorough. Thank you. Thank you again. Okay, next up, we have Jerry Griffin. He's the Vice President of Government Affairs from the Midwest Independent Realtors Association. Thank you.
Thank you, Madam Chair, members of the committee, for the opportunity to address the committee today. As you stated, my name is Jerry Griffin. I'm the VP of Government Affairs for the Midwest Independent Retailers Association, commonly known as MIRA. MIRA is a multi-state trade association. We were founded in 1910 in Detroit, thereby proudly celebrating our 115th anniversary this year. Over time, we've grown to accommodate a variety of retail sectors, largely focused in the food, beverage, and petroleum industries. Within the last decade, the Associated Food and Petroleum Dealers, as we were once known, merged with an Ohio trade group and changed their name to Midwest Independent Retailers Association, and now operate in several Midwestern states. MIRA and its members are deep concerns about the proposed cuts to the SNAP program signed into law at the federal level. These cuts could affect nearly 1.5 million Michigan residents who already faced uncertainty and higher costs when it comes to their monthly food budget. We represent over 1,000 family-owned business owners in Michigan, many of whom operate in urban and rural areas where big box grocery stores do not exist. We serve a large number of SNAP recipients whose only access to nutritional food is their local small independent retailer. Reducing or eliminating benefits to the elderly, working poor, and children served by SNAP will have a domino effect in cutting the sales revenue at our stores and the tax revenue at the state and local level as well, and force us to make hard business decisions that might further reduce food security for these needy individuals. According to data compiled by the National Grocers Association, the investments made in the SNAP program are responsible for 8,450 jobs in Michigan, employing Michigan residents serving in the grocery food industry. and nearly 5,000 additional jobs in supporting industries. These jobs generate $681 million in wages and $61 million in local and state tax revenue. These figures show that the SNAP reductions just do not make any economic sense. According to the U.S. Department of Agriculture, as we heard earlier today, every $1 in SNAP expenditure generates $1.50 in GDP growth. Additionally, increased SNAP expenditures have a direct correlation to increased farm incomes. These drastic cuts will have a devastating effect on our nation's farmers. In addition, the federal legislation would now require the state of Michigan to shoulder a larger part of the burden just to maintain the current benefit levels in the SNAP program. The State Budget Office has projected as much as $700 million would be needed to fill the gap. Clearly, this cannot be absorbed by the state without reduction in benefits to the SNAP program and its recipients, or other state programs like healthcare, education, or potential investments in infrastructure. We all believe no person in a nation as wealthy as ours should go hungry. It is a moral imperative that we help those less fortunate than ourselves. On behalf of MIRA and its members, I want to thank you for discussing this matter in committee and continuing to shine the light on the devastating impact these cuts will have on Michigan's neediest citizens. Thank you, and I'd be happy to answer any questions you might have.
Thank you, Jerry. Members, are there any questions? Senator Schenk?
Thank you, Madam Chair. Thank you for your testimony. According to the Congressional Budget Office, the bill that is causing these cuts will add to our deficit by about $3.4 billion over the next decade. And I know that in my district, just from the uncertainty since our president took office at the beginning of this year, quite a few businesses are saying that they're going to be shutting down. These are independent retailers. The tariffs are causing uncertainty. People aren't buying as much as they used to. So I think what I'm hearing from you is that this is all interconnected and that SNAP Ed cuts, could actually increase the number of independent retailers going out of business, which is going to, regardless, I'm sorry, I misspoke, trillion dollars, the deficit will be increased by $3.4 trillion, not billion. That these SNAP Ed cuts could actually reduce the number of independent retailers in our community, and so then reducing our choices as consumers, and that will have also rippling effects. And there are farmers in my district too who are struggling, partially because of the tariffs. It sounds like what you're saying is that they may also see harder times, and we may be losing farmers as well.
Well, speaking strictly from the standpoint of our members, I wouldn't be in a position to talk about the direct impact on farmers. There is a grave concern, as I stressed in here, that I know that in terms of our membership, more than 90% of our members accept SNAP. Some of our stores in particularly dense urban areas where there is no Kroger, Meijer, what have you, they trace 60-65% of their business to 2 days a month. If there is less revenue, if there's cuts made so these individuals cannot come in and get the only healthy food they probably get, then that means less revenue for our members, and which obviously has a domino effect, a trickle-down effect. There's certainly some tough business decisions that would have to be made at that point in time. So, anything that reduces the number of customers walking through our door, obviously that's going to have an effect, sure.
Thank you. I'll just say it sounds to me like a man-made induced recession.
Thank you. And thank you. Thank you for your testimony today.
Thank you, Madam Chair.
Appreciate it. Next, we'll go over to Dessa Cosma, the Executive Director of Detroit Disability Power.
thank you so much for having me. My name is Dessa Cosma. I am the founding director of an organization called Detroit Disability Power, which works to build the political and organizing power of the disability community in Detroit and across Michigan to ensure that we have full inclusion in our society. We are a membership organization with over 300 due-paying members and thousands of additional supporters. We are dedicated to policy and culture change to destigmatize disability and give members of our community a fair shake. Just for a little bit of context, 30% of Michiganders are disabled. We are part of every community in this state. We are part of every race and ethnic group, every religion, and every class, although we are disproportionately low income due to systemic barriers in education and employment. We are a hugely diverse community across disability as well. I am a person with a physical disability, one that I've had since birth. But the disability community also includes people with intellectual and developmental disabilities, cognitive disabilities like autism, mental health disabilities like substance use disorder, those who are blind, those who are deaf, and those with chronic illness and chronic pain. Some of us become disabled with age, illness, or accident. Many of us have multiple disabilities. You, if you are not already, will become disabled if you live long enough. There is so much to be done to make our state and our nation one that actually works for people with the diverse disabilities and life experiences that I just described. As a group, disabled people, especially those of us who are also people of color, low income, LGBTQ, and/or immigrant, are not doing well. But let me be very clear. There is nothing inevitable about the fact that we are not doing well. We are challenged and held back by prejudice, lack of accessibility, and bureaucracy. We are not prioritized in decision-making when it comes to policy change or development of the built environment. Did you know that only 2% of housing is accessible? Did you know that in most states, including Michigan, it is still legal to pay disabled workers less than minimum wage? Did you know that if two people who receive SSI get married, they are financially penalized for doing so? How are we to successfully navigate life if we can't get around? We're misunderstood and are an afterthought at best in most situations. We have been dealing with systemic failure and exclusion forever. And all of this is before the passage of H.R. 1. I am not being dramatic when I say that the federal cuts to Medicaid and SNAP are an existential crisis for disabled Americans who rely on these programs. We have been barely hanging on already, and I am truly terrified of what is to come for my community. The health and economic impacts for us are surely going to be devastating. It is estimated that 10 to 17 million people in this country will lose their health insurance due to these cuts. They will not quit getting sick or quit needing care. Instead, they will delay care and get sicker. They may delay care and end up in the emergency room, both of which are more expensive for them and for our healthcare system, and certainly worse for their health. A University of Pennsylvania Institute of Health Economics and Yale School of Public Health Studies showed this summer that 51,000 people in the U.S. will die unnecessarily every year directly as a result of these Medicaid cuts. That's 51,000 moms and dads, kids, grandmas, and friends. Disabled or not, these people are not expendable. And if you're thinking, no, Dessa, Medicaid is being preserved for those who truly need it, so people in your disability community will be fine. Let me disabuse you of that notion. Due to bias and lack of access, disabled people consistently fall through the cracks. Added so-called work requirements have already proven in states like Arkansas and Georgia to significantly reduce the number of eligible Medicaid enrollees. These are essentially job loss penalties, as they do not support people going through a hard time, but severely punish them for losing a job or turning in paperwork late. A vast majority of people on Medicaid who can work already do. As I mentioned, navigating a society that was not built with you in mind is a lot of extra effort and time, and often it frankly just doesn't work. As one example, I want you to imagine being a blind, rural Michigander without access to public transportation and an online system that is not accessible to your screen reader. How exactly do you navigate the additional paperwork requirements? Especially when there have also been cuts to the very services that could have assisted you in filling out the paperwork. Does that person not deserve health care? Or imagine that you're a person who needs assistance with activities of daily living. Home and community-based services, a benefit provided through Medicaid, pays for someone to come to your house to bathe you or maybe to change your tracheotomy. These aren't luxuries, they're necessary to one's daily living. They may be the very thing that allows a disabled person to work. But with Medicaid cuts, states are highly likely to roll back this program, which as of 2023 already had 800,000 people on the waiting list. We cannot handle less funding. In fact, we already needed more. Non-disabled Americans will suffer also, as healthcare costs will rise for everyone, hospitals will close, as we've talked about, people will be laid off, including personal care workers who facilitate the home and community-based services. I do not feel confident that our economy can handle the impacts of a collapsed healthcare system, and I certainly don't feel confident that our health can. I spent 23 years of my life on Medicaid. I needed that care, and millions of people rely on it today. So I implore you, protect your fellow Michiganders. You must blunt the impacts of these cuts however you can. Thank you.
Thank you for your testimony. Members, are there any questions? Again, thank you. Thank you for your testimony. Next, we'll have Alex Plum, the Executive Director of the Corner Health Center, who has provided both PowerPoint slides as also a written testimony. Thank you for being here.
Thank you, Senator Anthony, and members of the Senate Appropriations Committee for the opportunity to speak to you today. My name is Alex Plum. I'm the CEO of the Corner Health Center, Michigan's first and largest freestanding integrated health center specifically serving adolescents and their children. We're headquartered in Ypsilanti with sites throughout Washtenaw County and St. Joseph County. The Corner provides medical and behavioral health care for roughly 10,000 young people aged 12 to 25 and their kids from across Michigan. In doing so, we give away over $1 million annually in uncompensated care because the needs of our young patients exceed what they and their parents can pay. We rely on funding from the school aid budget, particularly the Child Adolescent Health Center program, which helps us to cover this balance and extend health care to vulnerable children in partnership with the state's robust Medicaid health plans. The federal budget reconciliation law passed in July puts all of this at risk. Community health centers like mine and around the entire state face devastating economic impacts because of the $1 trillion in spending cuts from federal programs including Medicaid and the ACA marketplace. This is what will happen to the Corner. First, the Corner will lose revenue. Approximately 75% of our patients rely on Medicaid, which accounts for $675,000 of our medical billing receivables. The Congressional Budget Office estimates that 7.8 million Americans will lose Medicaid, an 11% reduction in total enrollment. The Urban Institute estimates that 3 in 10 young people between the ages of 18 and 24 will lose Medicaid. If 11% of my patients lose Medicaid, the Corner will lose $75,000 in revenue. 30% would be closer to $250,000. In turn, the Corner will be forced to reduce how much we spend on staffing and on goods and services from vendors, most of whom are local Washtenaw County businesses. They'll also need to cut their spending on labor, goods, and services. These businesses, together with the Corner, will manage our cuts by laying off staff, by cutting benefits, and by reducing compensation. These are the secondary impacts to the cuts to Medicaid. But there's more, and it happens further downstream. The staff who are laid off will lose household income and their spending will be adjusted accordingly. They'll make fewer purchases, consume fewer services, and struggle to meet the expenses of daily living like food and rent. The Commonwealth Fund refers to these third-tier impacts as induced losses, and that's their pictogram in the slide. They note that because of these lost personal and business incomes, state and local revenues from income, sales, and other taxes like real estate taxes will also be reduced. A loss of $75,000 may seem small, but it's 2% of our budget. To put it into perspective, if two of the largest health systems in Michigan, Henry Ford Health in Detroit and Corewell in Grand Rapids, each lost 2% of their revenue, an incredibly conservative estimate, the impacts would be tremendous. According to publicly reported numbers from 2023, a loss of 2% to Henry Ford Health's revenue would be a loss of $90 million. For Corewell, it would be over $207 million. Think about the direct hit to our economy if we lose $300 million of revenue that would otherwise be spent on Michigan jobs, Michigan goods, and Michigan services. As of 2023, Michigan had 39 critical access hospitals, 10 of which were in the Upper Peninsula, along with 40 federally qualified and community health centers. These hospitals and community health centers disproportionately rely on Medicaid reimbursement. If their patients lose Medicaid eligibility and do not have commercial insurance through an employer, they'll have to turn to the ACA marketplace. But the marketplace is also being decimated. The bill did not extend marketplace enhanced premium tax credits, meaning on average, an average marketplace enrollee will pay $700 more in taxes and lead an additional 4.2 million people to becoming uninsured. These insurance coverage losses could generate $7.6 billion in medical debt. The Journal of the American Medical Association Health Forum estimates that by 2034, across the U.S., 302,000 jobs will be lost, $135.3 billion lost in reduced economic output, and state and local authorities will lose out on over $11 billion in tax revenue. And this is just because of the tax credits. In a comprehensive analysis of the economic impacts of the cuts, the Commonwealth Fund estimates that 1.22 million jobs will be lost by 2029, and in Michigan, it will lead to an increase in unemployment of almost 1%. The math is clear. If people do not have health insurance, they will stay sick longer, miss more work, save less, spend less, and require more public assistance. As my testimony has demonstrated, the economic impacts, particularly to children and adolescents, are profound. But in closing, I'd also like to point out the moral injury that this bill causes and what you can do about it. Low-income earners stand to lose the most. The Congressional Budget Office estimates that the lowest 10% of earners will lose, on average, $1,600 worth of health-related resources per household, while at the same time, the top 10% of earners will take those resources, helping each of their households gain an average of $12,000. This is a shocking and radical redistribution of resources from the poor, who already have so little, to the ultra-wealthy, and it is a sign of a very sick society. The Senate Appropriations Committee can help heal this moral injury by ensuring that the FY26 school aid budget protects Medicaid-matched programs like the Child Adolescent Health Center program. Over 300 child adolescent health centers exist in Michigan, providing comprehensive medical and behavioral health care to over 200,000 students in 59 counties around our state. How we choose to live alongside our most marginalized and vulnerable neighbors says everything about our state's true health. While the federal budget reconciliation bill aims to make us a sicker, poorer people, in Michigan it does not have to be this way. Senator Anthony, I'm grateful for the invitation to come and share the experiences of the Corner Health Center and school and community health centers like mine from around the state. Together with you and members of the committee, we look forward to working to redeem what is broken and restore health to all who come through our doors. Thank you very much, and I'm happy to take your questions.
Thank you, Alex, for your testimony. Members, do you have any questions? Senator Schenk?
Thank you. You touched on this a little bit, but you mentioned that there are hundreds of child adolescent health centers that provide comprehensive medical and behavioral health care to hundreds of thousands of students. And that's all over the state. But could you talk about sorry, I've got Invisalign every once in a while, it makes my tongue twist. What are some of the areas in our state that might be hardest hit by these cuts?
So I pointed out there are 300 child adolescent health centers funded by the legislature in 59 counties. So one of the goals that the Child Adolescent Health Center program has through the School Community Health Alliance of Michigan is to increase that this year. In fact, I believe that the Senate Appropriations Committee in the Senate passed a bill, your version of the School Aid Act included increased funding so that we could get additional child adolescent health centers in every county. The counties that are going to be disproportionately hit are our most rural ones and the ones serving urban centers. These are the areas where we have the highest rates of utilization in those community health centers by children and their families. So what we tend to see in those centers are young people who are coming that are either already on Medicaid or are coming for uncompensated confidential care. Confidential services in those centers basically include things like STI testing, pregnancy care, things that they need to be able to take care of immediately, and for whatever reason they're unable to access through their families. What we found disproportionately in the Child Adolescent Health Center program is that those families are unable to take care of those needs because they don't have sufficient coverage.
Thank you. I know there's one or two other member questions, but we do have a somewhat hard stop at 4. So I want to thank you for your testimony, and I know that you did provide materials for the members who have questions. So and our last individual who will be coming forward today is Dr. Deborah Brown with the Michigan Community Dental Centers. Thank you for being here.
Thank you, Chair and committee. I thank you for this opportunity to testify in support of protecting the adult Medicaid dental benefit. If you've ever felt the sinking weight of not knowing what you would do when you had a toothache, then you know what it feels like to land in the arms of our dental safety net. As a general dentist and the CEO of my community dental centers, which is Michigan's largest dental safety net, I see every day how vital the adult Medicaid dental benefit is. In 2024, our 28 centers cared for nearly 93,000 individual patients, including children, pregnant women, people with disabilities, and veterans, many of whom would otherwise go without any dental care at all. I would like to just take a moment to talk about the difference in physical and dental health for both the patients and public health. For patients, it is already difficult for adults covered under Michigan Medicaid to find a dentist to receive care. At my organization, in almost all of our locations, we are booking out new patients 3 to 6 months. A good portion of the entire state is a dental provider shortage area. For patients without a dentist, when they have a problem with their mouth, they end up in the emergency department, where they are typically given pain meds and antibiotics, and then told to see a dentist to resolve their issue. Now, from the public health perspective, the vast majority of all dental disease is completely preventable between good hygiene habits and regular checkups and cleanings. Basic restorative procedures are vastly cheaper and will allow patients to keep their teeth rather than advanced decay that requires crowns, bridges, and dentures. Dental care is very imperative to stopping preventable disease, detecting chronic disease such as diabetes, and keeping people in the workforce. Medicaid dental coverage works. It keeps people healthy, employable, and out of costly emergency departments. When dental coverage disappears, people delay care until problems become costly emergencies, costing far more to treat at that time. Poor oral health means missed school, lost work days, and worsened chronic conditions like diabetes and heart disease. Removing this benefit would limit preventive care, worsen health, and impose higher costs for our state now and in the future. Let us take a lesson from our history. The Medicaid adult dental benefit was eliminated in 2003 and 2009 due to severe budget challenges. On both occasions, it was reinstated as costs were shifted to emergency departments. Care was more costly and overall health declined. I've included a copy of resources that further document this for the committee. The impact also goes beyond adults. Research shows there is a strong association with adult dental coverage and positive oral health of children with Medicaid insurance. The truth is that Michigan's dental safety net is already at risk. The impact of any cuts will have far-reaching impacts, not only for MCDC, but all of those involved in providing care to people with Medicaid insurance. Cuts would force more providers, especially in rural and underserved areas, to scale back or close their doors permanently. When this happens, entire regions are left without care. It's not just Medicaid patients who lose. Everyone faces longer waiting times, fewer providers, and higher costs. Maintaining the dental benefit is essential to keeping the safety net intact. More than 2.6 million Michiganders rely on Medicaid for health care, including over 1 million children covered by Healthy Kids Dental. The state saves nearly $79 million annually on health care costs, solely from the adult dental benefit. Behind every statistic is a real person, a working parent, a new mom, a senior who depends on this care to stay healthy and stable. Medicaid funding is not just a line item. I urge you to please protect the adult Medicaid dental benefit and the health of the communities you all represent. And I thank you again for this opportunity.
Thank you. Thank you. Senator McMorrow.
Thank you very much, Madam Chair, and thank you for being here. Something in addition to the cuts to Medicaid are the concerns about the cap on student loan borrowing at $200,000. As you look at dentists, kids who are likely to go into dental school, which is significantly more expensive than other programs, can you talk just a little bit about how worried you are looking forward at the sustainability of programs like yours that can serve people who do not have private health insurance, people who are not those for-profit patients? What does that look like in your mind?
Sure, Senator. We already have concerns from our existing dentists concerning the public student loan forgiveness program. It is very difficult for safety net dental clinics such as ours to hire and be competitive in this marketplace. Our average dentists graduate with upwards of $500,000 in student loans, and the cap is somewhere going to be $250,000. So that will discourage people who look like me from being able to go to dental school or medical school. So I think it's going to have a huge effect on organizations like ours. Thank you.
Thank you. Any additional questions, members? Yeah, Senator Shing.
So this doesn't really require a response or just kind of a yes or no, because we do have to get out of here. I'm just guessing that the proposed cuts to vision, hearing, and dental screening in elementary school out of the House's Republican education budget, you're not a big fan of that, on top of these cuts?
No, Senator.
That's what I thought. Thank you.
Thank you. Senator Santana?
Thank you for your testimony. If Medicaid adult dental coverage were eliminated, or even some coverage of services were eliminated completely, what is the impact that would you expect Medicaid beneficiaries' overall health to do? Like, we've seen where we've tried to do a good job as a state to actually meet people where they're at, whether it be a mobile dental clinic if they don't have transportation. We've tried to make sure that in elementary schools we have services to provide preventative care for our kids. What does that look like from an emergency room perspective as far as cost? And if you can just elaborate on that a little bit.
Thank you, Senator. You will definitely see an increase in people using the emergency department for care. You will see many people not trying to access care until it is an emergency, where they have a swollen face with their eye closing. And there are every day people across the country being intubated or dying from dental diseases that can be prevented. So we will see those things happening.
Thank you. Thank you again. Members, I know this was a longer committee hearing, but the impact to our balance sheet, the decisions that we are charged to make in the next few weeks required this amount of information. So I ask you to take the materials, go back to your teams, think about how we can contemplate these significant cuts to our state's resources. With that, I see Senator Kavanaugh moves that we adjourn, and supported by Senator Santana. So without objection, the Senate Committee on Appropriations stands adjourned.